Lp(a), or lipoprotein A as it's called, is a genetically developed cholesterol that you have in your body. Roughly 20 to 30% of the world's population have an elevated Lp(a). And it's a triple threat, meaning it's got a bad cholesterol, so-called LDL, but also has proteins in it that increases its inflammation in the blood. And third, it has a propensity of making your blood clot longer than it should. So it's a triple threat. And unfortunately, right now, we have no medications that lower this lipoprotein. Statins actually might actually raise it. Some of the newer drugs, such as the so-called PCSK9 inhibitors, lower it by 15 to 30%, but not consistently. So we don't have a drug out there that works to lower this lipoprotein, which again is very highly elevated in a large patient population in the world. So because of that, there's been this technology of therapy called antisense. And these are new drugs that follow a pathway that actually inhibits the protein from being developed by inhibiting the so-called messenger RNA that makes the protein eventually through the DNA and so forth. And this blocks that protein production, and by blocking it, you reduce any protein you want. In this case, this drug reduces Lp(a) by up to 80% or so. So this study is a phase 2. Phase 2 looks at safety and efficacy of the drug in patients who have high Lp(a). And so these patients had a known history of cardiovascular disease and had an Lp(a) greater than 60, normal being 30 or less milligrams per deciliter.
So twice as much.
Twice as much. And it turned out in the study, the results, the average level was about 100 milligrams per deciliter. And the trial had multiple arms to it. All of them except for one had a drug dose of different amounts at different time periods. One arm had just placebo. And we followed them for a period of time looking at what effect it would have on the Lp(a) and how safe it was. And it turned out that the drug lowered Lp(a) at the high dose once a week up to 80%. And there are no adverse side effects related to the drug. So it was a significant benefit to these patients. It's amazing. That amount of Lp(a) reduction is quite dramatic, and we're hoping that it'll be quite significant. Now, the trial wasn't powered to look at outcomes, meaning who got cardiovascular events compared to who didn't. That's when you do a phase 3 trial. Now, that trial is initiating. It started in January of this year. It'll include thousands and thousands of patients in centers throughout the world. And basically, there'll be patients, once again, with cardiovascular disease, with Lp(a)s elevated, in this case over 70, and half the patients will receive the drug, and this time they'll receive the 80 milligrams once a month injection, and the other half will get placebo. And they're looking at 5 years estimate, and we're trying to see what the difference in cardiovascular events would be: heart attacks, strokes, death, whatever, compared to the two groups. And if this trial shows not only lowering of Lp(a) but lowering of cardiovascular events, then this will be next step FDA approval for use in this patient population. We call orphan because there are no drugs that are effectively being used presently that can lower it. The Lp(a) in this trial will be even higher than the other trial. They'll be up over 70 milligrams per deciliter. This drug is a new technology called antisense. And what this does, the drug makes the mRNAs make proteins through a process called transcription. First, you have translation of the DNA and RNA forms the so-called transcription of the protein. So this drug inhibits mRNA by causing a missense reading of mRNA. See, the mRNA is supposed to read a protein, but by this drug getting involved with the mRNA, it doesn't read the right protein. So it missenses it, so it doesn't make the protein. So it stops the protein production right in the beginning, where most drugs, so-called monoclonal antibodies, they're antibodies against the protein that's already been made. So this stops even before it's made. And it's a great technology because they have, with this drug, something called GalNAc. And this is additive to the drug where it goes, this makes it go directly to the liver and affects no other tissues. And that's where you make your Lp(a) is in the liver. So other tissues are ignored, and by having it so specific, this new version is 1/10 the original version is used. So side effects are almost non-existent with the drug. And it's very specific for lowering the Lp(a). KU was one of the few sites in the United States. There's only about 20, 30 sites in the whole world, and about 10 of them were in the United States. And we are one of the biggest sites in the country. And we recruited a large amount of patients for the trial in our center. And because my center deals with a lot of these patients on a regular basis, I was able to have an opportunity of offering them this drug for the first time. Since 20 to 30% of the population have a high Lp(a), we're talking over 1 billion people. And some patients, like African Americans, even have higher than Caucasians. And Asian Indians have higher than Chinese or Japanese. So it's definitely a genetic marker. And once you're born with it, that's it. It doesn't change. It won't go up, it won't go down of any significance. Diet, exercise, weight loss has no value. And in Europe, they recommend universal testing for adults of Lp(a) at least once. Just make sure if it's low. In the United States, our guidelines recommend measuring it after someone has had a cardiovascular event, which might be a little more reactive than proactive. And I think those guidelines will probably change as times go on. Cardiovascular events are designated heart attacks, stroke, unstable angina, peripheral arterial diseases, all these vascular diseases that are related to the process of atherosclerosis, which is the abnormal depositing cholesterol within your arterial walls. The American guidelines recommend testing it if you have a cardiovascular disease. Other guidelines recommend that you test everybody at least once. And some other ones say, if you have a high risk family history of heart disease and so forth, get it tested. And it's not an expensive test. Just ask your primary care doctor. You don't need to go to a specialist to have it tested. Ask them, can I have my lipoprotein A tested? I want to know if it's high. And if it's normal, then you're pretty well safe for the rest of your life not to have to worry about this lipoprotein. Unfortunately, presently, we do not have any medications that are approved for lowering Lp(a) levels. And in situations of dire need, where patients may have a high Lp(a) that's strongly associated to a cardiovascular disease, such as a heart attack or stroke, the only thing we have presently is a therapy called lipoprotein apheresis. And these are machines that filter the blood from a patient and take out all the bad cholesterol only, including LDL and Lp(a) by 70–80%. Therapies last 2 or 3 hours, and it's once every 2 weeks. Here at the University of Kansas, we have the largest center in the country treating patients with lipid problems that require lipoprotein apheresis. We have around 60 patients that we treat for what we call familial hypercholesterolemia, where they're very high LDLs, or for high Lp(a)s with cardiovascular disease. We have an 11-year-old boy who was transferred here from Children's Hospital who had multiple thrombotic strokes. And his LDL was normal at 60 milligrams per deciliter, but his Lp(a) was 160 milligrams per deciliter. So he started apheresis here, and now it's 5 years out. He's had no cardiovascular events. He's doing fine, but we have to keep him on the machine until this new medication that we're researching becomes available. The TV show The Biggest Loser, their protagonist that helps people lose weight, he had a heart attack last year. And it turns out his heart attack was related to Lp(a). And he went on Dr. Oz explaining this, that his disease was related to this lipoprotein, and as you know, there was no therapy for him at the time. So this is a risk factor for even the healthiest looking people. So it's not how you look or how you act or what you eat or what you don't eat. This is a genetic marker, it just needs to be checked, and if it's normal, then you can move on. If it's elevated, then don't worry that you can't treat it. What you can do is treat other risk factors. For example, even though statins don't lower it, what they do is they lower other cholesterol that are bad, then they can lower your risk of heart disease. And there was a study that proved that. Even though you had a high Lp(a), you still had benefit but it was somewhat attenuated compared to patients who had normal Lp(a). Using lipid apheresis for Lp(a) has been shown to be very quite successful in reducing cardiovascular events. In Europe, they had 3 major randomized trials. They were more retrospective than prospective. And we here at KU did a similar trial that we published last year in the Journal of Clinical Lipidology, where we had patients who had very high Lp(a), very normal LDLs, but they all had cardiovascular disease. And we had them on apheresis, and we followed them for 4 years. And we reduced their cardiovascular event rates by 94%. And we reduced their Lp(a) to normal levels, and their LDLs got down very low. And no one had any adverse side effects from the therapy. So in dire straits, such as this 11-year-old boy who had multiple strokes due to the Lp(a), apheresis could be used. It's not necessarily going to be used for everybody, obviously, because it's very invasive and very costly. But for those select few that have high risk of disease or have ongoing disease, it's a possible alternative. The apheresis did save his life, and his parents are definitely in agreement with that and are appreciative, and they still come back every 2 weeks.